Welcome to Mayo Clinic, and my name is Mike Hooten. I'm a pain specialist at Mayo Clinic, and the purpose of this talk is just to discuss a pragmatic or practical approach to managing opioids that is based in part on the CDC guidelines. Some key objectives, and there are just two. First, to identify key clinical elements of an opioid monitoring program that can be used in daily clinical practice. As we all know, the CDC guidelines are rather complex, and it's difficult to possibly implement or think about an approach to implement some of those key findings in daily practice. Second objective is to demonstrate a practical approach, again, to how these are implemented in a daily, busy clinical practice. So here is the little acronym that we'll be discussing. It is Be Careful. We published this in 2018 in the Mayo Clinic Proceedings, but since publication, we've added a couple of letters, which you will see as we move forward. Buprenorphine. I think the take-home message here is that it's not just only for opioid use disorder anymore. And in fact, it is approved for use in chronic pain. However, there's still some confusion about who can actually prescribe buprenorphine. Of course, if it is prescribed for opioid use disorder, a special exemption number is needed from the FDA. But if you're prescribing solely for chronic pain, that number is not needed. However, there's still quite a bit of confusion about that. Even as I talk with pharmacists, sometimes I have to remind them that the number is not needed because, again, they may not fully recognize it. But it's key when writing prescriptions that the indication is very clear. So, for example, if I'm treating someone with chronic neuropathic pain, I will put that exactly on their indication, chronic neuropathic pain or chronic nociceptive pain. Very important. And also, there are multiple formulations that are now available. So sublingual, buccal, transdermal. In my own practice, I prefer the sublingual formulation for a couple of reasons. Number one, patients are accustomed to taking pills, and it's much easier to manage and manipulate a pill, if you will, versus a very small or thin, buccal patch. Also, number two, the transdermal approach. It's a 7-day patch, so it's not very amenable to quick changes in dose that may be required. And then finally, the sublingual, the generic comes in 2 and 8 milligram formulations. And those tablets can be safely cut, which again gives more flexibility, especially when the medication is being titrated to the clinical effect. And of course, it's always difficult if someone is already on an opioid. How do you transition to buprenorphine? And this is an evolving practice where we're learning more and more, literally on a month to a year basis. For higher dose patients, my approach is to do a brief hospitalization, 1 to 2 days, to make sure that transition is safe and to mitigate any adverse effects, particularly acute opioid withdrawal that may occur. Otherwise, for individuals that are taking lower doses, maybe less than 30 morphine equivalents a day, 20 morphine equivalents, I will typically hold the opioid for 18 hours possibly, and then start a low dose of buprenorphine, following patients very carefully and titrating on a very low dose, oftentimes at 1 to 2 milligrams a day. And then there's this question about hyperalgesia. As we all know, opioid-induced hyperalgesia is a real phenomenon. It's measurable, and you can see it clinically. We're doing some preliminary work now that suggests that buprenorphine, at least in individuals that have chronic opioid use disorder, there does not appear to be hyperalgesia. But again, our results are just at the preliminary stage, but this is very important. Opioid contracts. As we all know, for 15 or 20 years now, opioid contracts have been recommended, and I think they are, really the mainstay in many institutions. There are two basic components as you think about which contract you may want to use. There's a patient responsibility and clinician responsibility. And again, there's many examples of various contracts available online. But at this point in time, the majority of health systems, other institutions have not one, but oftentimes several different types of contracts. And depending on where you work, what setting you're working in, those contracts, may be subtly different. But one important component that may not be fully expressed in some of these contracts is opioid consent. And I think that's a very important component of longer-term opioid use, because oftentimes in the context of pain, and individuals may not fully recognize all the potential adverse effects. For example, they may not recognize that over time you will become physiologically dependent, and that to abruptly discontinue the drug may result in acute opioid withdrawal. Individuals may also not be aware that tolerance can develop. Tolerance is very important, obviously, because patients may not recognize that the quality of pain relief, the quality of analgesia will diminish over time. And then another important point is patients may not recognize that as tolerance develops, some of the adverse effects will persist over time, specifically difficulty with GI motility. An important component to longer-term safety is assessment of addiction risk. This should be assessed, as we all know, prior to initiating longer-term opioid therapy, but also during the course of therapy. And there are many different scales and questionnaires that can be used. I think two of the most widely recognized are the SOAP-R and the CALM. The SOAP is meant to screen individuals for risk factors for opioid misuse prior to starting the drug. And of course, there's a sensitivity and specificity to that, as you can see on the slide. The CALM is meant to be used in the course of opioid use. So somebody has been receiving longer-term opioid therapy, and this measure is designed to be used to assess for development of opioid use disorder during the context or within the longitudinal context of opioid therapy. Now, one of the key factors or problems with any screening instrument is that there is always a sensitivity and specificity. Okay? And you can see that these instruments, which are some of the best that have been developed, those metrics are not very good. So if someone might test positive on either the SOAP or the CALM, the clinical data may suggest otherwise. So therefore, it's very important that these numbers are just not simply accepted, but they have to be interpreted. And oftentimes you may need to move against the numbers, again, because of this lower sensitivity and specificity. And that's where it's key, in my mind, to at least provide a narrative explanation as to why a positive score is being ignored, or why a score that may be actually negative is actually being honored and is being recognized that this person may have an opioid use problem. Another important factor that I think lends to using these two particular measures is that they are available online. They're in the public domain, and these, again, are widely used measures. Another important component of longer-term opioid therapy is identifying the effective lowest dose. This can be very difficult, but now the CDC has provided at least some general guidelines, to help us determine what is low, what is a medium dose, what is a high dose. But when the CDC guidelines were initially released, many patients that may have been taking in excess of 90 morphine equivalents, for example, were immediately, the opioids were immediately even discontinued, abrupt discontinuation, or a very rapid dose reduction to come within those guideline parameters. However, I would suggest that we've learned more about this. And if an individual, for example, might be on a stable dose of 120, 150 morphine equivalents, and they've been stable over time, I think it is very reasonable to slowly taper to reduce the risk of harm. But again, making abrupt changes just based off these guidelines is probably not in the best clinical approach to managing higher dose patients. Monitoring databases, which are now widely available, and at least here at Mayo, it's actually integrated into our health record. So it's becoming easier and easier to look at the prescribing the prescriptions that individuals are receiving, not just opioids but other controlled substances. This is very helpful, particularly with regards to identifying benzodiazepine use. Benzodiazepines, as we know, are intimately associated with accidental overdose deaths. These different categories of morphine equivalents are important because as that morphine equivalent rises, so does the risk of an accidental overdose. And that's why it's key to identify who might be receiving a benzodiazepine unknowingly, not recognizing the potential danger, but they can get that from another prescriber. So it's very important to document each time the monitoring basis access, put that in your clinical notes. In our system, it actually records whenever an individual checks, the monitoring database, but I always, like to put that in my own, documentation. Functional assessment is also really a key factor for long-term therapy because what we would like to see, obviously, is improvements in pain, but we also want to see improvements in sustained improvements in overall functioning. And I typically like to divide function into three big categories: occupational, psychosocial, and physical functioning. There are several ways that this can be documented in the record. For my approach, I like to provide a narrative. So when I see patients in follow-up, I will literally put in my note, what are they doing? Did they recently take a vacation? How is work going? Are they involved in recreational activities, playing golf, doing other enjoyable things? Are they attending, children's sporting events, school events? Are they involved with their grandchildren? These are the types of data that I think are very helpful to demonstrate how individuals are maintaining their overall functioning. Now, in addition, there are some ways to more objectively document that, and I think the brief pain inventory, is a document that's very helpful. I like the brief pain inventory for a couple of reasons. It not only addresses physical functioning, but it addresses emotional functioning. It also assesses the patient's perception of the benefits related to opioid use. It's widely used globally. It's recognized as a validated measure. And also, it's very brief. It takes patients no more than literally 5 minutes to complete. There's a shorter 3-item question, but again, I don't think it gets the granularity that the full measure provides. And of course, urine drug screens is another way to provide some objective data about how patients are doing. There are 2 components of the urine drug screen that need to be really well understood. The first component is step 1. That's the immunoassay. The second is the confirmation, which is either mass spec or liquid chromatography. And this is really what drills down because the immunoassay will identify an opioid is present, but the second confirmatory step will identify exactly what drug and metabolites are present in the urine. However, it's very difficult to know exactly what components are being tested for. That's why communication with the toxicology lab personnel is very helpful to understand exactly what is being screened for and then what is going to appear on the confirmatory testing. So not only do you need to talk with personnel and the toxicology labs, but a basic understanding of opioid metabolism is critical. And we're just going to run through a very quick and easy approach. So oxycodone, as we know, the immunoassay detection rate is very low. So individuals, they even may take higher doses. It may be missed on the immunoassay. Again, that's why the confirmatory testing is so important. Methadone, is another important drug. The parent compound may be missed, or if somebody discontinued methadone, you can definitely identify the metabolite, which is termed EDDP. Literally, that is an 18 to 20 letter word, very, very long. But that can be reliably detected for days afterwards. And then fentanyl. Fentanyl is a funny drug. It may or may not be captured on the screen. More and more, it is showing up here at Mayo. It is definitely screened for and identified in the confirmatory testing. So here's a little diagram based on oxycodone that helps understand, I think, the metabolism of at least three of the most commonly used drugs. So as we know, codeine is metabolized into three different compounds. Of course, very few people actually receive codeine in the current environment. But codeine is metabolized to both hydrocodone and morphine. Very important. Hydrocodone, a certain component, is metabolized to hydromorphone, which is dilaudid. Similarly, morphine is metabolized to hydromorphone. And here's, I think, the value of this little diagram. If someone is taking hydrocodone, you will see possibly some hydromorphone, okay? But if someone is taking hydromorphone, you should not see hydrocodone. That would suggest that they could be using both drugs simultaneously. Similarly, a certain component of morphine is metabolized to hydromorphone, but the reverse again is not true. Hydromorphone is not metabolized to morphine. So the presence of hydromorphone, if that's the primary prescription, and if you see morphine in the urine screen, that suggests that the individual might have an alternative supply of morphine. And also, the two do not cross. So morphine is not metabolized to hydrocodone, and the reverse is also true. Hydrocodone is not metabolized to morphine. So I think that's the value of this very, very simple diagram. And again, it probably hits the major drugs that are prescribed. But probably in my mind, the most important component of long-term opioid therapy is longitudinal in-person follow-up, consistently scheduled over time so the patients know exactly when their follow-up date is expected. And again, this is the framework upon which all the other components of this monitoring program are based. And again, no follow-up, no prescription. And because if an individual misses an appointment, something is going on. There's been a problem unless that individual provides information about where they might be at that time. For example, I've been following patients for years now. Some individuals have routine scheduled vacations. They let me know 3 and 6 months in advance. And then, of course, we allow for that, which is obviously very important. And then the next question becomes, how can we feasibly implement this in a practical way in clinical practice? Well, here's an example that we try to follow here in the pain clinic in Rochester. As you can see, every 3 months, individuals come to the clinic for an in-person evaluation. And we typically have just divided it, the start of each quarter. So January, April, July, October, we see patients for 30 minutes. We assess function, we assess addiction, we obtain a urine specimen for toxicology screening, and they're giving the prescription renewal. Obviously, we use electronic approaches, but there are some patients that still like the paper copy. On the off months, in between those time periods, we then review the medical record. I typically like to review that with one of the nurses who also works with our opioid renewal clinic. And then we sit down, we look at the record, we assess the prescription monitoring database, and then we provide the prescription renewal by mail or electronically. This is an important component of the renewal process because it provides literally monthly assessment of how the individual is doing, Were they hospitalized? Is something else going on in their health care that we need to consider? And sometimes, because we really take care of a complex medical and surgical population, it's not uncommon for our patients to be hospitalized to undergo certain types of therapies. And then, of course, we adjust the prescription renewal accordingly. Also, a key component of this approach is that all of our prescriptions are synchronized. So we follow a number of patients, and everyone's prescription is renewed at the same date every month. Now, this is important because what this does is that it eliminates these daily calls or several calls per week from different patients asking for their renewal. And that really consumes a tremendous amount of time. And also, it may not provide the opportunity for clinical staff to fully assess what has happened since the last prescription. So synchronization of all prescriptions, I think it improves quality of care, but it also is much more efficient. So in summary, the Be Careful model provides a practical approach to ensure that the key components of the CDC guidelines are actually in place and patients are actually benefiting from these important guidelines. Also, it provides the basis for a pragmatic approach to follow patients longitudinally to ensure safe use of these medications. Thank you very much.